Well, welcome to KidneyCAN's 2025 Looking Back, Looking Forward Town Hall. Really appreciate you all taking time out of your day to see us today. Thank you to the audience. We have almost 200 registrants from 32 states and 21 countries joining today. So thank you very much. This town hall is going to be available on our YouTube channel in a few days. So look for an email on that. And we especially want to say thank you to our sponsors, BMS, ASI, Exelixis, Genentech, and Merck. But a big, giant thank you to our panelists today. We're really pleased to have all the way from California, Dr. Monty from the City of Hope, and also Dr. Laurence Albiges at Gustave Roussy, all the way over in Paris, France. Happy New Year belatedly. Thank you for joining us, Dr. Powell and Dr. Albiges.
Thanks so much for having us.
Great. Well, I'm going to...
Thank you.
Thank you, Laurence. Dr. Powell, I'm going to introduce you to look back for us. Give us what you saw in the rearview mirror in 2024. Then we're going to have a couple of questions, and then we're going to ask Dr. Albiges to talk us through about looking forward, what's on the horizon in 2025. We'll take a few minutes, about 10 minutes to hear from you. So the floor is yours, Dr. Powell.
Okay, that sounds great, Brian. Just a quick check. Can you all see my screen okay? Oh, you know what? I may be sharing the wrong screen there. Let's flip that around. How's that? Is that good, guys? Okay, very good. Excellent. Well, I have the tall task of describing what's happened in 2024 in kidney cancer. And thankfully, there's a lot. A lot of it is actually driven by my colleague, Dr. Albiges, on the screen, and a really terrific community of investigators that KidneyCAN so graciously supports. I will say, as I was seeing the check-ins today, I see a lot of familiar faces on the line from Southern California. So I just wanted to say a quick hello to those of you that I know personally who joined the meeting. Hopefully this will be a really valuable resource. I certainly think that it tends to be. So what's happened in 2024? These are some of my disclosures. I've titled my talk 2024, but I will say what I'm going to describe today is kind of 2024-ish. I'll probably date things back a little bit further just for purposes of discussion. I'm going to squeeze a lot into 10 minutes, but again, I'm happy to field questions after this. Implementation of belzutifan, I think, is one of the big updates, at least stateside here in 2024. And really, this is work that's been driven by Dr. Albiges and her team that led this study. So Dr. Albiges first presented this at ESMO, our big European meeting, 2 years ago now, I believe. Correct me if I'm wrong. And the trial is one that I think is really critical for patients with kidney cancer. It addresses an unmet need. These are patients who have progressed previously on treatments such as immunotherapy or targeted therapies. Targeted therapies encompass drugs like sunitinib or, for instance, cabozantinib, et cetera. And patients in this study were randomized to receive belzutifan or everolimus. Now, belzutifan works in a very different way. It was the subject of the Nobel Prize not long ago and blocks certain pathways that we think feed the tumor oxygen, more or less. So it works in a mechanism that's distinct from what we've seen in previous years. And Dr. Albiges 2 years ago presented data that really gave us a sense that this drug works in general for patients who have received prior therapies. And she's really distilled that further to show that this drug seems to have activity across multiple lines of treatment. So whether you've gotten one prior line of therapy for kidney cancer, whether you've gotten 2, whether you've gotten 3, this is an agent with very good efficacy and something that I think represents a very valuable addition to our armamentarium. So I know this is a complex series of graphs, but really what it's meant to articulate is that there is benefit with this approach across multiple lines of treatment. And I'm happy to dissect that further. It seems to work whether you've gotten 1 targeted therapy or 2 or 3 targeted therapies. So, fundamentally, when I look at the green curve versus the red curve, the green curve represents belzutifan. The red curve represents everolimus, an older standard that we've had in our armamentarium for many years. It looks as though patients getting belzutifan consistently do better. For individuals who are on the call who are looking for novel options, I would certainly host conversations with your oncologist around the appropriateness of belzutifan. Actually, I wanted to showcase some of the data that she's presented at the KidneyCAN meeting. So every year in Boston for the past several years, KidneyCAN has graciously sponsored a meeting that brings together a lot of us kidney cancer investigators. I think it's a really essential meeting for those of you that are interested in volunteering. I'm sure you can contact Brian after this, but it's an awesome venue where we can really sort of dissect the clinical science. And what Laurence presented there for the first time is data that pertains to some of the toxicities that we might see across various groups. And, what really sort of stands to demonstrate from this data is that it looks as though the toxicity of belzutifan stacks up quite well against everolimus, the historical standard. So, it suggests that this is an agent that not only demonstrates efficacy, as we showed in the previous slides, but also safety. I wanted to talk about a really hot topic, and that's the role of sequential treatment. So, this is a conversation that I've probably actually had with several of you who are on the line today, and that is around the role of continuing immunotherapy. So, if you think about diseases like breast cancer, I don't know if many of you know this, but I actually started as a breast cancer researcher when I was a fellow, and I was in the lab of Dennis Slayman, who really was behind the pioneering work for this drug called Herceptin. It was a really exciting time. And one paradigm that emerged is that you kind of continue this drug Herceptin, I'll use the trade name trastuzumab, through multiple lines of treatment, right? So, when somebody progressed on drug A, you'd keep the Herceptin going as a backbone. When somebody progressed on drug B, you'd keep Herceptin going as a backbone. That same sort of thing is something that I saw happening in kidney cancer in a lot of second opinions that I saw. So, me and several colleagues, Dr. Albiges was one of them, set out to do this study, which looked at whether or not there was a role for continuing immunotherapy. So we looked at targeted therapy with or without immunotherapy in patients who had previously gotten immunotherapy. So we were seeking to determine whether or not it makes sense to keep immunotherapy going from the first line to the second line to the third line and so on and so forth. And really, all that we demonstrated very consistently in this study is that there didn't seem to be benefit with this approach. Now, this is a 2023 paper, so I cheated a little bit here, but the same data has been replicated in 2024 by our colleague Tony Choueiri. So what he presented was a study looking at tivozanib, a drug with that also falls in that category of targeted agents. And so this looked again at patients who had gotten prior immunotherapy. It looked to see whether or not continuing immunotherapy with tivozanib rendered any benefit. And frankly, there didn't really seem to be any difference in clinical outcomes. So this was data that was just published last year. So, my message to you is that, if you're thinking about, continuing immunotherapy past your first line of treatment, past your second line of treatment, think again, because it may potentially cause some harm. It may not necessarily yield clinical benefit. And I think that's something that's emerging from these studies more recently. This is a big update. And, I hope many of you are having conversations, if relevant, with your oncologists around this topic of adjuvant therapy. Adjuvant therapy refers to the principle of us reducing the risk of cancer coming back. Right. So in breast cancer, chemo is often used in this concept, sometimes hormonal therapies. In the context of colon cancer, again, chemo is a very common strategy. And kidney cancer, for many years, Dr. Albiges and I really had nothing really viable that we believed in. But that's all changed with this series of 4 clinical trials. This was a really ambitious effort to really characterize whether or not we could use immune therapy, which we've already highlighted has activity in kidney cancer, could potentially benefit as a preventative strategy. It could probably take me a full hour to go through all this data, so I'm going to highlight what really is relevant in clinical practice now. So again, our colleague, Dr. Choueiri, led this study looking at pembrolizumab, which you may know as Keytruda versus placebo for a span of 1 year. And I want to be very specific about who this applies to. So it's patients primarily with their kidney tumors removed surgically. So if you have your kidney tumor removed surgically, if there's no evidence of cancer present, and if your risk is high enough, right? Because you don't want to do this if you have a low risk of cancer recurrence. But if your risk is high enough, you may be a candidate for this therapy. There's also a niche population of individuals who, for instance, have 1 or 2 sites of metastatic disease that's surgically resected. They're also candidates for this approach. But what's big in 2024 is that he and his colleagues showed that this improves survival. Now, this is a really big deal because whenever we employ treatment in the adjuvant setting, our first and foremost rule is do no harm, right? We want to make sure that we're not harming patients. And I would say that if we're improving overall survival, it suggests, in my opinion, that a lot of the toxicities that we encounter along the way might potentially be justified because the amalgam, the cumulative effect of this data is to improve overall survival. So this data really swung the pendulum for me. For most patients with, again, high-risk kidney cancer that's been removed from the body, right, with no evidence of disease surrounding, and in those nuanced cases that I mentioned beyond that, I am using pembrolizumab or Keytruda in this setting. Now, this is a study that me and Laurence ran together looking at a different drug called atezolizumab or Tecentriq. And I do not want to suggest that people use this drug as adjuvant therapy first and foremost. When we ran this trial, we were initially disappointed to see that there was no difference. You can see these curves are overlapping for this drug, atezolizumab, versus a placebo. I'm super grateful for the patients that participated in the study, though, because what Laurence has really dug up is the fact that when we looked at the blood from these patients, there's a specific protein, and this protein is called KIM-1. And this protein, I like this volcano plot here because it's complicated, but it shows that this protein really stands out in the pack in terms of something that might be enriched or more prevalent in patients that have disease coming back. Right, so Laurence presented this data at our big meeting in Chicago, ASCO, last year. And it was really a huge, in my opinion, meeting highlight. This is the first time that we really have a good biomarker to tease out who might potentially really benefit from adjuvant therapy. So what Laurence showed all of us at that meeting is that if you actually have a high level of KIM-1, those are the individuals that might potentially benefit from immunotherapy. If KIM-1 is low, you may not benefit. Now, this is not a marker that I would suggest is ready for prime time, but I wanted to mention it because as we look forward to 2025 and beyond, and I don't want to step on Laurence's toes because she's going to give us an overview of what's to come, but I do think that this is going to be a really important piece of work moving forward that I'm super excited about. I'm going to switch gears here in the last portion of my talk, and I'm going to really try my best to stay within 10 minutes here and talk about early signals for microbiome modulation. And this is, I put a little asterisk here because this totally reflects my personal bias. If you look to many 2024 updates, I don't know that this would really sort of rise to the top, but I do think it's a really interesting concept. And I'm having lots of conversations with my patients in clinic around this. I can't think of a single clinic visit over the past year that I've had with, patients either on the line today or otherwise, where we haven't at least talked a little bit about diet, right? I mean, we've had some conversation around what patients should be eating, what patients shouldn't be eating. And as you can tell from the content of today's lecture, I think me and Dr. Albiges, we're very evidence-based. We don't want to tell you what to eat unless there's really sort of sound science behind it. So we're kind of working towards that. These are two of my terrific fellows. Well, one of them, Dr. Disman, I think is now kind of a household name in kidney cancer. She's just wonderful. So she's a medical oncology fellow at MD Anderson. My other fellow here, Hediye Ibrahimi, comes from Iran, and she's doing some work here in Los Angeles with our group now. But they published these two papers that I think have gotten a significant amount of attention amongst my patients. And these studies looked at a Japanese compound called CBM588. This is a live bacterial product. And so this bacterial product enters into the gut. And the way that we think it works is it's a spore. So it actually makes its way through the gastric acid, doesn't get digested there. It's able to surpass that. It actually goes into the large intestine, the last part of the gut, sits there, and it grows and it proliferates. And we think that it's able to actually secrete components into the bloodstream that boost immunotherapy response. So the principle here is cool, but we needed to do these preliminary trials to vet whether or not this actually works. So Nasli ran this study looking at immunotherapy with CBM588. Hediye ran this trial looking at targeted therapy with immunotherapy with CBM588. And I'll just point out here in the interest of time that it looks as though the responses seem to be higher with CBM588 versus without. Now, again, I think we're all rigorous scientists here. So I wouldn't say that this is by any means data that should prompt anyone to purchase CBM 588 and do this on their own. Just like with any agent, we still need to vet the safety, the toxicity, and the efficacy of this approach. There is going to be a study that's launching, hopefully, within the US, what we call cooperative groups. So this is a trial mechanism that allows for us to research concepts sponsored by the federal government here in the US. And it's going to look at targeted therapy and immunotherapy-based combinations with or without CBM 588. So I think that's an important move forward. What else is kind of happening in this space? If you wanted to get CBM 588 right now, we do have a couple of slots left on this dose escalation study looking at immunotherapy with CBM 588. So we're trying to actually take that dose that we looked at in the initial studies and ramp it up a little bit. And then my other fellow from Mexico City, Dr. Barragan Carrillo, is doing this really cool study where she's actually looking at this natural substance called camu-camu. Camu-camu is something I'd never heard of a couple of years ago, but there's an investigator in Montreal, Bertrand Rudy, who's done some beautiful work. And this is what's highlighted in this box here, suggesting that you can boost the impact of immunotherapy with camu-camu. So we have a study that's ongoing right now, just a couple of slots left on this trial looking at immunotherapy with or without camu-camu. So a lot of things that we think can be done with natural substance to boost the gut microbiome. Now, I'm probably a little bit over time here, but if you'll indulge me, I just have one more slide that I wanted to show. It's really not just our group that's interested in the microbiome. It's this massive international effort. And this is a really cool study run by my Italian colleagues called the Tacito, or maybe Tacito, but my Italian is very bad. But this is a study that looked at a totally different approach. So this is complicated. It's called fecal microbiome transplant. And it actually takes stool from a donor patient, and it actually transplants that stool into the gut of an individual who has kidney cancer. So we do this through a variety of different mechanisms. We can either do capsules, we can transfer the stool through colonoscopy. But the principle here is very similar, right? We're trying to modulate the gut in a way that actually enhances response to immunotherapy. This was a really tricky study to do because they actually supplied all the stool for the 50 patients in this study from a single donor. So, you have to take the data with a bit of a grain of salt, because if we're going to go further with this, it really requires the stool of that very benevolent donor. But this study looked at a typical targeted therapy, immunotherapy regimen with or without stool transplant. And the results actually looked pretty compelling. They looked at the proportion of patients that didn't have worsening of their cancer at the 1 year mark. And they saw that was better if you got the stool transplant versus not. So in any case, if I were to sort of summarize here, I think the big updates from 2024 are, thanks to Dr. Albiges' implementation of belzutifan. It's a great option that we should discuss. I do think that we should have some pause in using a sequential immunotherapy. And when it comes to adjuvant treatment, I think it's definitely a discussion to be had with your oncologist, and look to the future for biomarkers like KIM-1 that Dr. Albiges has presented to us in the investigative community. Not ready for prime time, though. And also look for trials of gut microbiome modulation. I do think it's the way of the future. So with that, I'll stop sharing my slides. Thank you for your attention.
Wonderful. Thank you, Dr. Powell. Appreciate that. And I know we've got a few questions we got to hit here, and I'm going to ask Dr. Albiges, you can join us if you can. And I think first up we have from the great state of New Jersey. Cindy, are you out there? Yes,
I am. Can you hear me?
Yeah.
Perfect.
Okay, great. Thank you so much for being here. Here's my question. Have there been any advancements in rare subtype kidney cancers?
That's a great question. I think this is something that me and Dr. Albiges talk about quite a bit. I'd love to hear your perspective as well, Laurence. But, I do think that the major advance over the past couple of years has been the suggestion that certain targeted therapies, in particular cabozantinib and lenvatinib, may have superior activity in some of these rare subtypes. And that's a long discussion because we need to really get into the weeds around which subtype we're dealing with here. I think Dr. Albiges has some very compelling data for the combination of lenvatinib and pembrolizumab that she's published that addresses multiple rare histologies. We have some trials, and maybe this is perhaps the most element to encourage. We have some trials that I think will definitively address whether or not we need immunotherapy as a component of some of these combinations. In the US, we have a trial called PAPMET-2 that looks at cabozantinib with or without atezolizumab for papillary kidney cancer. And worldwide, there's a study looking at sunitinib versus a newer targeted therapy called zanzalintinib with nivolumab for advanced disease. So those are the two studies that I really encourage folks to look at. Dr. Albiges?
Yeah, great question, Cindy. So I think I would add the two things. First, we're getting better at classifying non-clear cell. I think our pathologists are doing a great job now to call FH altered or, like potentially other subtypes, chromophobe. And I think we're getting better at this. So please, if you are being diagnosed with a rare form of kidney cancer, it's important that you are confident with understanding which kind of kidney cancer it is and have some time, a path review to make sure that we are all agreeing on the diagnosis. And the other thing on top of Monty's comment with the different data that are currently being generated is last ESMO, we had a prospective study of doublet IO, so namely nivolumab plus ipilimumab versus standard of care. It was a European academic effort led by our colleagues in Germany, and the trial was named Sunny Forecast. And the bottom line is that in this study, the primary endpoint, which was the percentage of patients that were not progressive at a defined time point, was met with a doublet IO, so no TKI. And although it's a mixed bag of different rare tumors, I think it speaks to the fact that even IO, so doublet immune checkpoint, can play a role in those rare entities. Now, there's a work ongoing to try to identify. It's very hard to conduct research in this kind of situation because we need many patients. And so it's not easy to lead trials like Dr. Paul is doing right now with the international STELLAR study.
Thank you.
Thank you, Cindy. And just sticking with rare subtypes for a second here, Dr. Paul, Dr. Albiges, there are other affiliate organizations around the globe that are listening in today and representing kidney cancer patients around the world. Is there anything that they could be doing to help support the progress in developing more treatments for rare subtypes on a more global level?
I'm going to take that one. I'm going to start, Brian. I think we need all of you to lobby for the access to new drugs. And so it can happen at different levels. One could be making sure that there are trials that are open for patients with those rare tumors, meaning making sure that it is being across as widely as possible. And then there is also the question of access once a drug is being approved so that it's being reimbursed, although in those rare entities, because sometimes you have labels that are quite narrow, specific to clear cell and so on. So I think it's both on the research side as well as on the access side.
Fair enough. Thank you for that. We've got another question. We got a lot of questions to try to get to. So Michelle from Florida has a question for you all. Michelle?
Thank you, Dr. Albiges and Dr. Paul. My question for you is, has any further research been completed on finding a biomarker or early detection for kidney cancer?
Yeah, maybe I could take a first stab at that one. It's challenging because we've done a lot of work with circulating tumor DNA. So this is the DNA that's kind of shed from a tumor. And one of the challenges is that this approach has been really, really helpful in diseases like bladder cancer, for instance. We find that, bladder cancer tends to shed a lot of DNA into the periphery so we can identify recurrences quite early. In kidney cancer, it tends to be a really low shedding disease. And so that makes it really tough for us to detect these bits of DNA in the circulation. I'm optimistic that hopefully over the course of time, we'll identify elements that can potentially and identify experimental techniques that can actually help us increase the sensitivity of these tests so we can capture disease before it happens on scans. But I don't think we're quite there yet. I actually think the most promising potential biomarker is what Dr. Albiges had presented last year in KIM-1. But again, to emphasize, and I'm sure we both agree on this, we need really sort of rigorous testing to find the right clinical application of that.
Yeah, Michelle, it's a great question. I think we need to maybe have two different perspectives. One is that useful for screening, and then you want something that is very sensitive. It could be urine test, blood test, or that's something that we could use to monitor our patient after surgery, like we are doing in some other tumors, to see if there is any signal in the blood that the patient is having a recurrence and have early treatment or maybe decide on adjuvant. So yeah, I think that KIM-1 fits well there, but it needs to be prospectively validated. And we are all looking forward to have more data in this space. It's a bit lacking. We're a bit behind with RCC, but there are many teams working on this.
Thank you both for that answer. Another question is coming in all the way from Maryland. We've got Sarge. Sarge, good to see you. You're on the air.
Hi. Are there any new developments in treating bone metastases? Thank you.
Everybody get that question on any?
So thank you. So bone mets is a very challenging situation because it's highly symptomatic and it's invalidating. And so I agree with you that we need to work on this. I initially had planned to put slides in my deck that we're going to discuss afterwards on this, but the data will not be for 2025. So I end up not putting them. I'm quite enthusiastic about the strategy of testing radioligand therapy. This is something we are doing in other cancers, such as prostate cancer, that are prone to go to bone as well. And so this is very early ages, but there are different companies that are currently working on the idea of having radioligands. So this is something that is like a bone scan, but the device is actually delivering local radiation therapy, if I may explain that properly. And so I think this is a way to carefully look at. Radium has been tested. I'm looking at PSMA right now because it's highly expressed on endothelial cells. So it's the right target for RCC as well. And so in Europe, EORTC is testing. I'm pretty sure that in the US, there will be trials here in the same setting.
Maybe I'll just add too, since I was charged with the 2024 look, what kind of is in the current state right now is that I think we're a lot more excited about the prospect of using site-directed radiation for bone metastases. So, if I were to flash back to 18 years ago when I started, if we saw that new bone metastases were arising on a scan, right, we would rarely think about just treating those in isolation. But now with really, I think, promising data emerging around radiotherapy, if I see a patient who has perhaps one new bone metastasis or two new bone metastases emerging, and this is very nuanced, it really depends on the clinical condition of the patient and many other factors, I might consider site-directed radiation therapy there and actually keep the same base therapy, if you will, going.
Great. Thank you, Dr. Powell. One quick follow-up question from Poland for you, and then we're going to turn it over to Dr. Albiges to look forward here. And the question from Poland was, is there any room for belzutifan in treating RCC patients beyond these certain subtypes or histologies, if that makes sense? Did that make sense?
Oh, yeah, sure. Sorry, that was belzutifan beyond clear cell histology?
That's correct.
I see. I generally don't advocate for it just because I think in biologic principle, I would expect that it would work in clear cell disease. So, whereas I do have a little bit of laxity in applying other targeted therapies in non-clear cell kidney cancer, I can't think of an exception to this, frankly. I reserve belzutifan for my clear cell patients. Laurence, is that your practice as well?
Yeah, I was about to echo that. I fully share your point of view. It's really driven by the biology of clear cell RCC. We do know that there is angiogenesis in other non-clear cell subtypes, but it doesn't make as much sense. And if it would be used, it would be, to my perspective, has to be in combination. And we need to then generate data to build a rationale around this.
Great. We got some questions about camu and the gut microbiome to come back to, but we've got to go look forward a little bit here. So Dr. Albiges, we'll give you the floor here to talk a little bit about what the horizon looks like for 2025.
Thank you. And thanks again for the invitation to be part of this town hall. I'm actually very excited to spend this time with you. And so Monty has perfectly set the stage of where we are and where we are going. So these are my disclosures. I'm a medical oncologist in Gustave Roussy in France, and both my clinic and research focus on RCC. So I'm going to start with localized RCC. And so one of the questions is, can we better select patients? And this is still a work in progress. The second one is about adjuvant. So Monty highlighted the fact that we have data that led to the approval of pembrolizumab, which demonstrated both the ability to delay time to disease relapse, but also an overall survival benefit. And the other studies turned out to be negative, although there was a signal across the different studies in different subgroups and so on. So one study is still pending. So this one is likely to read out in the coming months or so. It's the last IO or IO-IO. It's the Rampart study. So durvalumab versus durva plus tremelimumab versus active monitoring. The study was stopped earlier because the change in the standard of care. Okay, so the sample size of this trial will not be able to fully address the question, but that is the remaining study we're waiting from this era. Now, what I'm waiting for, and it's unlikely to read out in 2025, but still I wanted to introduce you to the concept, is that pembrolizumab has also now been tested in combination with belzutifan on the ground of the rationale that Monty elegantly presented. And because this drug is well tolerated, so it makes sense to try to offer that in the adjuvant space. It's fully accrual. We're waiting for the results of this study in the future. Now, we're medical oncologists, so we learn from one tumor type to another one, and we bridged, okay? And so we're learning a lot from melanoma. And what the melanoma doctors have been able to do in the past was actually to say, instead of doing surgery and then providing adjuvant, meaning post-surgery treatment, why not providing treatment before and potentially afterwards? And so there has been 2 different studies which tested this hypothesis in melanoma. And the reason why I'm showing you this is that, to me, it's highly significant to see that in those 2 trials, the use of IO, either single agent or IO-IO, in the neoadjuvant space, meaning when the tumor is in place, potentially because this is where all the tumor antigens are being presented to the immune system, is clearly impacting the overall outcome of the trials. So treating while the tumor is still here, then performing surgery, so before surgery, is actually doing better than doing after surgery alone. And so as of now in RCC, we don't have this data and we need to generate that. And I hope in the future we'll be able to make those major steps that has been done for melanoma colleagues. Another step I'm looking forward, which yet here is still under investigation and will not likely to have the results in 2025, is something we have also learned from melanoma. We are now able to generate personalized vaccine. What does that mean? It means that we're using the tumor that has been operated on to perform a personalized vaccine strategy. So we build an mRNA, or at least a neoantigenic vaccine strategy for one patient, and this is being tested in combination with pembrolizumab. So this is not yet a huge registration study, but these are the data that were generated for melanoma patients. Positive signal, and this is something that is now being tested for RCC. So it's not yet the registration study, but it's a proof of concept that we need to establish for patients that having surgery for renal cell carcinoma, to explain that we can do better with combining this approach along with pembrolizumab. And this study is enrolling worldwide, although it's a small study for now. So what about first line? First line is when patients have developed further disease progression, so metastasis, and require systemic therapy. And current standard of care are either combining one immune checkpoint inhibitor plus one VEGF TKI, so the IO TKI strategy, or 2 immune checkpoint inhibitor, nivolumab plus ipilimumab. And so as physicians, we're looking forward to have more follow-up. Why is the follow-up question important? Because you may be familiar with the fact that there are several regimens that have been approved. And what we've seen over time is that when you combine one immune checkpoint inhibitor plus one VEGF TKI, you are clearly making a huge difference. But over time, this difference is actually being reduced. And so what I'm showing you on the right is the magnitude of benefit that we're seeing in those trials, very deep initially, but then over time, not as strong. And what we want is to have, a bit like in the top right part here, something that is very stable over time. It means that the benefit we've had is sustained over time. So I'm eagerly waiting for having further follow-up. We're expecting this for the Checkmate 9ER study, and it will be presented in the coming weeks at ASCO GU, where we will have more follow-up. Another strategy is to say, oh, we want to combine the best of both worlds. So we want to have 2 immune checkpoint inhibitor plus 1 VEGF TKI. So we have deep response, very strong benefit initially, but also sustained over time. And that was the rationale of the COSMIC 313 study. Many of us took part in this triplet trial. So first time we were having 3 drugs being offered to our patient. Of course, it means more toxicity, but what we want to see is, does that impact long-term outcome? And at the coming ASCO GU meeting, we'll have the overall survival data along with some translational work. So, like more biomarker analysis built on this trial. This is something we are waiting for. And so with regard to triplet, COSMIC 313 is not the only study which tested the hypothesis of having 3 drugs. And this is a trial that has fully been accrual, so all patients have been enrolled. And here again, we're trying to move from 2 drugs, the arm C, one standard of care being lenvatinib pembrolizumab, and adding a 3rd agent. So either belzutifan, the drug that Monty presented, or a CTLA-4 inhibitor. And so this study is waiting to read out. So we are waiting for these results. I think this is a very important phase 3 as well. Now, the challenge we're having when we see a patient for which we want to start systemic therapy is that we have 2 standards, IO, nivolumab, ipilimumab, or IO-TKI. And here I mentioned cabozantinib, nivolumab, or lenvatinib, pembrolizumab, or axitinib, pembrolizumab. And so how can we guide our treatment strategy? And I want to share this design with you. It is a trial that is not open in the US. It's an academic trial. So like it would be like a consortium, a cooperative group in the US. That's the equivalent. And here we're testing the strategy of IO versus IO-TKI. And the reason why I'm showing you this design is that it is a trial that has been designed with the support of patient advocacy group. And this is where I really feel we need you to make a trial that is patients-friendly, informative for the patient. And IKCC, one of its French affiliates, Arthur, has been extremely helpful here. And this trial is now open in 4 countries in Europe and will be up to 11 countries. So maybe in the future, we'll be able to answer what's the best strategy for our patient, and can we use PD-L1 to guide our treatment selection? What about late lines? Monty spoke to those findings of belzutifan. As a physician, this study has been important to me because it's providing a new mechanism of action to our patient, meaning new drug that works differently from the others. IKCC and KidneyCAN represent international patient advocacy. And I want to highlight 2 things on this slide. The first one is to the left is the FDA approval that was December 2023. To the right is EMA approval, that's December 2024. So with regard to your question, Brian, how can we help? We need to lobby to have prompt access to the drug. And this is very meaningful to me. I want to make sure that all patients have access to innovation and to new approved agents. And that is highlighting the fact that you can play a role to lobby to have access to those new drugs. Now, what about new drugs? Targeting HIF, meaning targeting this biological pathway, belzutifan paved the way, but there are other agents that are currently being developed. And in 2025, we'll know more from casdatifan. This is another way of inhibiting HIF that will be presented. These are only phase 1 data, so small numbers of patients. But whenever you have a new class of drug, you don't only have one agent. You can have several of them, and sometimes they're getting better over time. So as physicians, we want to see more of these HIF inhibitors. And it's likely that because those drugs are well tolerated, we want to combine them. And so I'm waiting for the results of this study, the LightSpark. Oh, sorry, I don't know why it's hiding. Can you still see my screen? I think we've lost the screen, so I'm going to share again. Anyway, so we're going to have combination data that I'm eagerly waiting for. I hope that will tell us if we need to go for combination therapy or stay with single agent where we are treating our patient, including in late line setting, meaning when they have failed prior combination therapy. Monty have shown you that it wasn't the case for immune checkpoint inhibitor. And so the question is, do we need to do that with a TKI plus belzutifan, our first HIF2 inhibitor? And so I'm going to move on now to the question of non-clear cell. We had a great chat around, is there anything new? I didn't put national studies. Monty mentioned PAPMED2 in the US. I think it's a very important study. We have PAXIPEM here in France. These studies are important because they are randomized. And whenever you want to assess the contribution of the component, you want to make sure you have the right comparator, okay? And so as of now, for non-clear cell, it's hard to have randomized study. And really, Monty has paved the way when he initially compared sunitinib with cabozantinib. And this is another good example of we are comparing single agent TKI, sunitinib, with zenzalutinib plus nivolumab, so potent VEGF TKI plus immune checkpoint inhibitor. So we need randomized study, and although it won't read out in 2025, I strongly suggest that you take part whenever you are eligible to this kind of study. And I'm going to conclude on 2 aspects. And the first one is, what are patients' expectations? I am looking forward in 2025 to have the readout of the Global Patient Survey on kidney cancer. Why is it important to me? Because I need to understand what are the patients' understanding of their disease, what are they keen on seeing progress being made. And this is extremely meaningful to me to have almost 3,000 of patients that are answering those surveys. So I look forward to these results. This is something I'm usually using in my talks to highlight this is what patients are waiting from us or are trying to understand when we explain the disease to them. And in this regard, I love the KidneyCAN motto, because to me, we're exactly trying to get to the same goals. You know, it's building awareness around kidney cancer. It's advocating, we discussed that already, and funding research and targeting cure is what we're looking for. When Monty and I started kidney cancer, very few patients could be cured, and the one that could be cured were the one that had localized disease. But whenever the disease had spread, it was much more difficult to get to a point where we can tell the patient, you're in remission. Right now, we have the opportunity with our treatment to see cure in our patients that have metastatic disease. But the number of this situation is not big enough. And so we need to make the next step to have more and more patients, although with advanced disease, being cured with our treatment. And with that, I'm going to stop here so that we have time for questions.
Great. Thank you, Dr. Albiges. That was wonderful. A lot of information to unpack. And as we continue with the questions, we're moving geographically sort of east to west across the United States. And our next question is coming from Tennessee, I believe. I think, Sid, are you there to ask Dr. Albiges a question, or Dr. Paul?
Yeah, Dr. Albiges and Dr. Powell, I appreciate you guys being on today. So my question is, what trials are you closely following that could impact practice in the next 5 to 10 years? I know you guys both have kind of touched on some different ones, but in general, which ones are you looking at?
So I think triplets is important. Do we intensify treatment? Treatment selection, I mentioned CARE1, but there are other trials such as the OPTIC trial being led by Brian Rini to try to use gene expression profiling to inform treatment decision. Non-clear cell randomized study, I mentioned the Stellar randomized study from Monty that is very important to me. And ultimately, I really want to do better in the adjuvant space. So I really want us to be able to select to who we should give adjuvant, and can we, maybe really properly select the patients that are more at risk of having disease relapse.
I don't know that I have too much to add to that. I mean, I think that's brilliant. Those are really the ones that I think are going to be the most impactful within the next 5-year horizon. I think you're absolutely right, Dr. Albiges.
Great. Thank you, Sid, and appreciate that. And we're going to go probably a little bit faster here if we can, because we're running out of time and we got a lot of people who want to ask you questions. So we're continuing moving west towards Oklahoma, it looks like. I think we got Maggie Burns from Oklahoma who's going to ask you all something. Maggie, you got the floor.
All right. Thank you so much. And thank you for your time with us today. I'd like to know, are any new treatments on the horizon for previously treated renal cell carcinoma folks?
Great question, Maggie. So we really want to make access to new mechanism of action, okay? So we mentioned the combination therapy of belzutifan on top of VEGF TKI. This is one example. But Monty, you can speak to the CAR-T strategy potentially, because you've been paving the way here as well.
Oh, you're very kind. It's something that I'm really interested in, Maggie, is the concept of these engineered T cells that are programmed to attack kidney cancer. I have to be totally candid with you. We're nowhere near at the place with CAR T cells as, for instance, they're at in diseases like lymphoma and myeloma, where you hear about CAR T as being a potentially curative strategy and effective in a large proportion of patients. We're really at a very nascent stage with CAR T and kidney cancer. Having said that, we do have a number of interesting compounds that are in pipeline. If I may, I'll just name a couple very quickly. We published data with a first generation compound called CTX130, and we have a second generation construct called CTX131. There's a trial that's ongoing nationwide. I'm less involved in that nowadays, but we had the first couple of patients on a trial looking at a compound called ALLO316 or ALLO316. And we saw some initial data around that at a meeting last year with reasonable response rates. I think the toxicity profile is something that needs to be balanced. We also have an autologous CAR T cell protocol, meaning we actually take the patient's CAR T cells and modify them and then reinsert them with a company called Arsenal Bio. That's a really interesting one. So there's a huge number of CAR T protocols that are underway. I do think that they require, if I were sort of to think through how to apply these CAR T trials, I do think that they require having the backup of very strong hematology programs, because this is a technique that is well known to our hematologists at this point, but a bit of a black box for us in the oncology space. So if you're pursuing these trials, I would, my tip, if I do have one here, is to ask about the hematology backup in these particular programs and to ensure that they've got good, robust support to manage patients.
Okay, thank you so much.
Thank you, Maggie. Those are great summaries. We have several questions from our audience on the topic of immunotherapy. Has a consensus been reached on how long a patient should be on immunotherapy?
So let's consider we're talking about patients that are treated in first line. The way the trials have been designed is usually 2 years if the treatment is still active, meaning that if the patient had further disease progression and a required change of systemic therapy, then usually we stop and we considered, as Monty showed you, that there is no role of sustained PD-1 or PD-L1 inhibition. So the answer is in the trials it's been to be 2 years. Now, there are efforts to define if we should de-escalate, meaning maybe stopped earlier, de-intensified. And with regard to should we stay longer than 2 years, there have been data generated in lung cancer, not in RCC. Monty, do you want to add anything to that?
No, I think that's perfectly stated. This is something that we struggle with. I think that the whole concept of de-escalation of therapy, going from an industry standard of 2 years, which is what I think many of us accept as a minimum in some cases, to a lesser duration, is challenging, right? It's a difficult concept, I think, to latch onto. And from a patient perspective, in my opinion, it's hard to take the standard of care and move backwards from that. And I think that's why a lot of these trials that have attempted that in other disease types have been unsuccessful. But it's a concept that I'm very interested in.
Got it. All right. It looks like we're moving back a little bit east towards North Carolina. And I think Lisa has a question for you. Pretty broad question.
Yes. How close are we for a cure for RCC?
I could jump in with that. I think Laurence actually had alluded to this in her presentation. I want to say, Laurence and I have kind of grown up together in the field. I think we've been in it for about the same amount of time, about 2 decades now, maybe a bit more than that. But when we started out, I think the cure was, really on the distant horizon. And we started incorporating checkpoint inhibitors in the frontline setting. I think that started changing things a bit. We started seeing people with these long-term remissions of disease. So there's certainly a proportion of individuals in whom we can achieve cure. I think the reality is that for the vast majority of our patients with stage 4 disease, and that's the bulk of what both of us see, at this point in time, the disease remains incurable. But I will say, I'm hoping that we're moving it more towards a chronic disease. I think that the data seems to be pointing to that over time. When patients come in and see me nowadays, I'm not trying to dodge the question around prognosis or survival, but as many people who I see on the line today would probably attest, you just can't crystal ball prognosis in kidney cancer anymore because it's changing so fast. Over these past 2 decades that the two of us have been in the field, we've seen more than a dozen approvals in the disease, right? And that's drastically changing how far we can take our patients. So, I like to mix in that question around cure with the element of maybe turning this into a chronic disease like diabetes or hypertension. That would ostensibly be another goal of mine over time.
Thank you.
Thank you, Lisa. I don't know, Dr. Albiges, did you want to respond to that, or we've got another question right on the footsteps here.
No, I think Lisa, the way we speak to our patient has changed, okay? I moved from, this is not a disease that we can cure, to we do have like 1 patient out of 10 that can be long-term remission, including without treatment, okay? And so this is definitely has changed the way we are approaching this. My new goal is to cure my patients, and every week, if I see more than 10 patients, I know that one of them ultimately can be cured, but I want to increase this number.
Thank you.
Great. And we're going to bring up Josh from Boston area to ask. He had asked a question, or we had heard a little bit about CAR T just a few minutes ago. Dr. Powell, can you explain briefly what CAR T is for some of the folks in the audience who don't know exactly what that means?
Yeah, absolutely. So, I think we're all familiar with our white blood cells, right? Our white blood cells are our body's main defense against infection and so forth. But another function of white blood cells is actually to really survey for any bits of cancer that are, within the bloodstream, and hopefully attack those elements as well and recognize them as foreign. That doesn't often happen in the context of our patients with advanced cancer. So CAR T is really a mechanism by which we really drive those white blood cells towards the tumor, right? And within white blood cells, there's 2 general subtypes, T cells and B cells. I usually think of B cells as being the smart ones that are sitting, and serving as sort of a memory of distant infections and so forth. And the T cells are the front lines in our military defense against infections. And what we try to do with the CAR T premise is reprogram those T cells so that they can recognize cancer as being foreign and go after it. This has clinical consequences, right? It's oftentimes when we inject CAR T cells, they're not perfect. They may go after certain targets that are not just expressed on the cancer, but on normal tissues as well. That explains some of the toxicity that we see with these agents. oftentimes when we program these CAR T cells and insert them into patients, right, it can also induce these massive flu-like symptoms that you might anticipate when your body's defending itself against a major infection. And those are things that we've learned to, protect against using certain drug-based strategies. So there's certain risks and rewards with this approach that need to be counterbalanced. Josh, does that address your question or?
Yeah, I think you pretty much did it there.
Great.
Thank you for everything.
Thanks, Josh. We thought we might be able to attack two birds with one stone, I guess is the way you say it. So a couple of quick comments before we have to wrap up here. We heard recently that there's going to be subcutaneous, which I guess is an injection for Opdivo here in the near future. Do you feel like that's going to be a change in the way care is given?
Okay, I'm going to take that one. I actually recorded the podcast for ESMO today on this topic because I led this trial. So it's IV versus sub-Q. It's not new. It's been done for other disease, including breast cancer for HER2 inhibitor. It has been done also in lung cancer for atezolizumab, and now it's in RCC that it has been demonstrated for nivolumab. It's a non-inferiority trial showing that if you administer sub-Q, it's 5 minutes administration. It's in terms of exposure to the drug, equivalent, non-inferior, equivalent, and even numerically superior to IV administration. And this is being administered every 4 weeks, okay? And so this study is a proof of concept. It's going to lead from my perspective, but we're pending authorization to the approval. It is important because it will be applicable to all their tumor types, all the different settings of the disease. And my feeling is that it's going to impact Brian a lot because from a patient perspective, 5 minute walk in, walk out is different from an IV port for 30 minutes. So it is clearly meaningful. And from our perspective, Monty and I are involved in our institution to make sure our infusion rooms are running well. And it's not the same to have 5 minutes occupancy versus 1 hour occupancy to put the IV and so on. So to me, it's very meaningful, Brian, and it's important that patients get access to this way.
Thank you so much for that. I'm going to ask the closing question here. Monty, I'll let you answer first, and Laurence, you can finish. Any closing thoughts for the community listening today regarding the future of kidney cancer research? Bright, gloomy, somewhere in between? Anything? I'll let you go, Monty, and then Laurence.
I'm a constant optimist, so I'm going to say very, very bright. And I love having this forum to articulate a lot of the development. So thank you, Brian. Thank you, KidneyCAN, for this opportunity. And thanks to everybody who's listening.
Yeah, to me, this is very important for us as well. You're doing an amazing job pushing research, amazing job lobbying to get more funding for research. Research is what is making us do progress so that we can cure RCC. So many thanks, Brian, for all the input from KidneyCAN.
Well, thank you. And thank you both for being here today, folks. I imagine you watched the news. A lot of grants for research were under attack over the last 48 hours. There's still a lot of work to be done in Washington. And so I'm going to, shameless plug. You heard it from Dr. Albiges. We need you. We need you at Spring Advocacy Days. We're going to be held March 11th and 12th. And we can use your voice on Capitol Hill. Registration can be found at kidneycan.org. And we've also dropped in the link right here for you to start registering. So again, thank you folks for joining from around the globe. I know this is a new time for some of you, so we appreciate from wherever you are listening in. Can't say enough thank you to our sponsors, BMS and ASI, Exelixis, Genentech, and Merck. And if you want to rewatch this town hall or share it with your family or friends, it's going to be available on YouTube at the end of the week. And once it's uploaded, we'll send you a message. So our next town hall is scheduled for April, and we're going to focus on the patient voice and find out from folks what it is you wish you'd known at the time. And right after this, we're going to have a community social. Please feel to join in and join us with friends around the globe. Here's the link. It's going to be in the chat. And again, can't say enough thank you to Dr. Albiges and Dr. Powell. On behalf of all of us, thank you all for joining, and we wish you all the best of health. Thanks very much.